we are in an obesity epidemic.
It is in and of itself a real disease, which leads to over 200 other health complications. Starting in, 70s, 80s, 90s, the numbers have just been going up and up and up.
We used to think of gastric surgery or gastric bypass, bariatric surgery. Now we think about GLP-1s.
People with obesity, to treat their disease effectively and long-term, they need medical intervention.
Are GLP-1s really the revolutionary drug of the next century?
Obesity treatment should not be synonymous with just a GLP-1 prescription.
What made you get into obesity medicine to begin with?
What we do, very high level, evidence-based, comprehensive academic medicine, obesity care delivery, and scale and democratize access. Most people who come in are totally hopeless, blaming themselves. They've lost and gained 1 million times. Nothing's working.
I'm Dr. Anthony Rossi, and this is Give Good Face, a podcast focusing on skincare science, and how to maintain and shape a healthy lifestyle. Hey everyone, welcome back to Give Good Face podcast. I'm super excited to have a good friend and colleague here, Dr. Katherine Saunders. She's an obesity medicine specialist, physician, who is also the founder of FlyteHealth, which is a complete online obesity medicine practice. We'll dive right into that as well. But as you know, we talk a lot about Ozempic face here and what that is, but we're really going to go beyond that and actually talk about the science of obesity and what obesity medicine is and how it's affecting so many of us in America and worldwide, and what good practices we can do to live a healthy lifestyle, maintain good, proper weight, and just a lot of stigma that goes into weight loss or weight gain and, all the science behind it. So let's take it away. Hi, Dr. Saunders. How are you?
Great. Thank you, Dr. Rossi. Thank you for having me here. I'm thrilled to be here.
Katherine and I are also on the Weill Cornell Medical Alumni Association together. You're the head of the entrepreneurship group, right?
Yes.
And tell us a little about that, because you started FlyteHealth.
Mm-hmm. So we started our company in 2019. I did all my medical.
Perfect timing.
Yeah, I know, right?
Yeah.
Exactly. Yeah. Right before the pandemic. It was great. My background is that I'm a physician, initially trained in internal medicine, and then I subspecialized in obesity medicine. I did all of my training at Weill Cornell with Dr. Lou Aroni, who's one of the pioneers of the field. After my fellowship with him, I joined the faculty and practiced for several years before we started the company in 2019 to basically take what we do, very high level, evidence-based, comprehensive academic medicine, obesity care delivery, and scale and democratize access.
That's so cool. Yeah.
Yeah, it's been a wild ride.
Yeah. And especially because, we overlap somewhat in medical school. And I remember in surgery, I was like scrubbing into gastric bypasses as a medical student, but I feel like that landscape is now suddenly shifting.
It is shifting. I think there will always be a role for bariatric surgery. The obesity medication landscape is just absolutely exploding. We have medications now that can enable people to lose as much weight or more weight compared to bariatric surgery.
Wow. I definitely want to talk about that as well. There's a lot of misconception about this. So there's so many questions I want to ask you. And because, you and I have been talking about this for a while, and you presented to a group that I was with, and I was just fascinated by everything you were saying. Because, when dermatologists or plastic surgeons think of weight loss, we used to think of gastric surgery or gastric bypass, bariatric surgery. Now we think about GLP-1s, but there's a whole host of medications, right?
Exactly. Yeah. So talking about all the misinformation, it used to be thought that obesity was just an issue of eating too much and exercising too little. We know that obesity is actually a disease. It's a really complex, chronic, heterogeneous, difficult to treat disease. And so, the cornerstone of the way we treat obesity is optimizing diet, exercise, lifestyle. But for most people with obesity, that's not enough. If you take a look at the numbers with lifestyle interventions, people lose 3 to 5% of their body weight with the best lifestyle interventions, and then they regain 80% of that within 5 years.
So that's just diet and exercise.
Yep. And so for most people with obesity, to treat their disease effectively and long-term, they need medical intervention.
So we need to stop thinking about obesity as just an intake of calories and an expenditure of calories or energy. It's like you're saying, a chronic multi-organ disease, right?
Exactly. Yeah. So they're dysregulated hormonal pathways and inflammation that happens in the area of the brain called the hypothalamus. And so it is, in and of itself, a real disease, which leads to over 200 other health complications.
Wow. Okay. So it's not just about willpower, right?
No.
Because so many people are saying that, oh, I was doing so well on this diet and then I had a slip up and, now I regained all that weight plus more.
Mm-hmm.
But there's genetic factors that go into it. There's also epigenetic factors that are going into it. What made you get into obesity medicine to begin with?
Yeah. So at Cornell, I'm sure you had the same lecture that I did as a medical student when we were third-year med students. Dr. Aroni gave a talk about how obesity is a disease and how he had devoted his career to developing effective treatment protocols. And when I heard him speak as a third-year medical student, it just blew my mind. I thought it was the most fascinating thing I'd ever heard. So I started working with him in residency. All started a fellowship program. So I was the first fellow at Cornell and one of the first in the country. I just fell in love with the science of obesity.
We had a pandemic, but we are in an obesity epidemic, would you say? Or has that been going on for how long now, would you think, especially in America?
Yeah, I mean, if you look at the numbers starting in, 70s, 80s, 90s, the numbers have just been going up and up and up.
And so when someone joins FlyteHealth, what happens? Because unfortunately, I've seen a lot of patients actually get GLP medications, on the internet, and they don't have it under the regulation of a physician. Mm-hmm. They're coming in with extreme weight loss and this whole idea of Ozempic face, obviously, like this rapid weight loss that they look cachectic or, really withdrawn in their face just from all the facial fat loss. But you're saying that doesn't actually need to happen.
So there's a lot of inappropriate care happening right now. In an ideal world, people would be able to see an obesity expert like me who does everything in a really thoughtful, comprehensive way. So when a patient comes to see us, they fill out several intake forms that assess basically everything that's going on related to weight. So, what events have led to weight gain, what medications they're on, what complications they have. We screen everybody for sleep apnea. Very thorough evaluation. We also look at a very thorough panel of labs. So by the time we meet someone, we have a sense of what's going on. And then we do an extremely comprehensive weight history, just complete medical history. And so during that initial visit, it's really nice because most people who come in are totally hopeless, blaming themselves. They've lost and gained 1,000,000 times. Nothing's working. They're just, a lot of people are like, oh, you can't help me. I just, I've tried so many times and I've lost and gained. And so we do this evaluation and basically use that information to then educate them on, this isn't your fault. This isn't willpower. This is a disease. And in your case, this and this and this and this have contributed. And then we talk about, a very comprehensive treatment plan where we optimize dietary strategy, we optimize physical activity, we talk about behavioral techniques. And then for most people who come to see somebody like me, nothing else is working. And they're very good candidates for medical intervention. The thing to remember is that, obesity treatment is not or should not be synonymous with just a GLP-1 prescription.
Got it.
First, we have so many other medications other than GLP-1s. And second, it can't just be a prescription. It has to be everything I just talked about to figure out, what somebody's obesity looks like and why they want to treat it and, come up with a whole wraparound plan that supports, the medications and provides tons of education and support.
Because I would imagine by the time they get to you, they have tried multiple things and they have to be on some sort of cycle of readiness or acceptance psychologically to, pursue even more. I think there is a psychological component to weight gain and weight loss.
Oh, yeah. I mean, it's tremendous, tremendous, tremendous. I mean, it is just so incredibly frustrating for our patients to try so hard over and over and be able to lose weight. But then what happens is that our bodies have been evolved to be really good at not starving. And so, think about any diet somebody goes on. At a certain point, you start thinking about food more, your metabolic rate slows down, you burn fewer calories with the same exercise at a lower weight. The body just does whatever it can to push weight back up. And it's so demoralizing for people to go through this cycle. Some people call it yo-yo dieting. A more clinical way of talking about it is kind of weight cycling. And each time it can get harder and harder. So literally by the time people come to see me, they're totally hopeless. And it's so exciting for us to be able to explain to them that it's not your fault and to give them hope that we know exactly what's going on and we have great success.
And it's really a lifelong disease and a lifelong commitment, right? Mm-hmm. So, I'm sure you're following patients for quite some time now.
Yeah, it's a chronic disease, so lifelong. The phase of weight loss is totally different than the phase of weight maintenance. And weight maintenance is for life, and everybody hits bumps in the road. And so preparing people for those bumps and to let us know as soon as possible if they start getting off course so that people don't regain 100 pounds and then come back to see us.
After the initial intake, because this is all virtual now, right, on FlyteHealth?
It is all virtual.
Okay, that's amazing.
Yeah.
And you're in all 50 states, even better. After the initial intake, what happens? Do you start people on medication? Do you also prescribe exercise and fitness, or how does that work?
Oh, absolutely. There are very few patients we probably don't start medication the initial visit, just again, because of what they've experienced before. Yes. So we make dietary recommendations. All of our patients meet with dietitians, and we spend a lot of time talking about physical activity as well.
Is it difficult for people to make the initial jump, or is that the easier part and then the maintenance is the harder? I'm so interested in the psychology of it, because even when someone comes to see me for skin-related issues, they've been thinking about it for a while before. Yeah.
Everyone's like, oh, I can lose weight so easily. That's the easy part. And most of the time, weight loss is easier than weight maintenance. But weight loss can also be really hard if you've done it a lot of times and your body's just so resistant. So we never make assumptions, and we just kind of take it as it goes and see what happens and adjust the treatment plan based on people's responses. Weight maintenance is hard. Everyone comes in being like, oh, I can lose the weight, I just can't keep it off. And it's because our bodies aren't designed to lose weight and keep it off.
For sure. Yeah.
So it's really hard, really, really, really hard.
Hey everyone, I want to take a quick break from today's episode to introduce you to a fantastic tool, Hygge Health Light Therapy. This light therapy device harnesses the power of red and near-infrared light to promote skin rejuvenation, reduce inflammation, and even help with collagen production. It's a safe, non-invasive way to brighten up your complexion, ease muscle tension, and improve your mood, all from the comfort of your home. I've seen remarkable benefits with light therapy, and Hygge Health makes it easy and accessible for everyone. So if you're serious about glowing from the inside out, Hygge is your go-to. Check out hyggehealth.com and use code GiveGoodFace for an exclusive discount. Glow brighter, live better with Hygge Health. So we consider Botox like the revolutionary drug in the field of dermatology. There's many of them, but are GLP-1s really the revolutionary drug of the next century, or?
Yeah. All the hype is pretty warranted. We use GLP-1s, but very strategically. So not in every single patient. Not everyone needs a GLP-1.
That's a good lesson for everyone to hear. Yeah.
Not everyone needs a GLP-1.
Yeah.
We have other medications. Think about other fields of medicine. We rarely jump straight to the most powerful, most expensive injectable medication. We usually try several other things first, especially considering that this is a chronic disease that needs to be treated long term. But GLP-1s are really exciting meds. The ability to reduce inflammation, the ability to, decrease the risk of heart disease, death, all of these studies right now looking at addiction, so many different kinds of addiction, liver disease, kidney disease, sleep apnea. Because there are over 200 weight-related health complications, having a very effective way to treat obesity and other mechanisms as well. It's not just about the weight loss. It's incredible, the potential of these meds.
Yeah, I feel like I'm reading a study highlight every other week about a GLP-1 and its positive effects on, not just weight loss, but
Mhm.
other cardiovascular risk factors. But it does cross the blood-brain barrier, right? So there is an effect on this addiction, sort of like
Mhm.
gambling or alcoholism.
Yeah.
Can you just dive in a little deeper on like what a GLP-1 is? How does it work and why does it work?
Yeah, that's a great question.
Yeah.
I feel like a lot of people don't talk about
No, yeah.
what is going on here.
Yeah.
There are several aspects we don't fully understand. Basically, what a GLP-1 medication is, GLP-1 is a hormone that we make when we've eaten. So you eat a meal and your GLP-1 level goes up. It's produced by your digestive system, and it basically
So
tells
the gut.
Mhm.
Okay.
Basically tells your brain that you're full. And
So there's that gut-brain connection.
Oh, yes.
Yeah.
And that's obesity. I mean, obesity is hormonal pathways that get dysregulated between the gut and the brain, the fat cells and the brain. Exactly. And so giving GLP-1, so basically a mimic of the hormone that we already make, makes people feel less hungry. They feel full faster and they stay full for longer.
Science is amazing.
Science is so amazing.
Yeah.
It's so cool,
really is,
right?
yeah.
It's so cool. But if you think about, some of the pathways that are involved in food and kind of the hedonic drive to eat overlap with different kinds of addiction.
Got it.
So it's really cool. But it's funny. I have some patients who are on a GLP-1 and they're still very interested in alcohol. It doesn't touch them. Some cannot even look at alcohol, and then many people in the middle. So there's variability in response.
So there's still a lot more we need to understand. And now newer medications are coming out, like these triple Gs that are sort of like 3 different G hormones.
Exactly. So because obesity is such a complex disease, there's so many pathways. It's similar to, hypertension, where many people are on 2 or 3 different agents, some as combos, maybe some separately. With obesity, the way to treat obesity more effectively is to target multiple pathways at the same time. So if you think about semaglutide, which is Ozempic and Wegovy, that's just a GLP-1. If you think about the medication tirzepatide, which is Mounjaro and Zepbound, that targets 2. It's GIP and GLP-1. And then retatrutide is triple G, targets 3 pathways.
Wow.
And there are hundreds of drugs in development, many of which target more than one pathway.
So in essence, I'm going out on a limb here, you could become resistant to one GLP or?
Yeah, that's an interesting question that we still need to learn more about. There is some element sometimes, I think, in some cases of resistance, like when someone takes a medication, stops, regains the weight, and then the same medication may not work as well. We need to understand that better. But different people's obesity is different. So they're different genotypes, they're different phenotypes. And so there are non-responders, which is like shocking because there's so much hype about all these meds that I just did a piece for Associated Press about, what it's like for non-responders and, the fact that this happens.
Yeah, that could be, I'm sure that's debilitating because people think that this is like the panacea of weight loss. But I think it does underscore something very similar in dermatology and plastic surgery, is that you really need to go to someone who understands what the whole science is about, not only exactly what you're doing in the moment, but the downstream effects. And we always talk about like really going to see a physician who understands, the skin, understands the biology, understands all the nuance. And same for you, because there are so many people who are getting these medications willy-nilly.
Yeah.
And they're starting at super high doses compared to where you would start, right?
Yeah.
One thing I learned from you is that these side effects of like nausea, vomiting, not eating for 1 day or 2 days are really not supposed to be there.
Different people respond differently to any medication we give them for weight. And we always start with very low doses and only increase as needed and as tolerated. And by doing that, if someone's starting to have a side effect, we'll pull back or keep them at that dose until the side effect resolves before increasing. But you hear stories about people who just don't eat for days. Like that should not be happening. Or people who have really bad adverse events, which also, they're warning signs. Like someone's constipated for a while before they have a small bowel obstruction or before they have diverticulitis. So this needs to be done responsibly.
Of course, I don't think people realize that there are issues with these medications. There are adverse events like any other medication, right? It's a risk-benefit ratio, right?
Yes, and that's a great point. These medications have only been studied in people with a body mass index over 30, body mass index of 27 with a weight-related comorbidity. And so for people
That's
who
like
are
diabetes, high blood pressure.
Exactly. And so for people who are taking these medications who are of normal weight and want to lose 5 pounds, they just haven't been studied like that. And you have to think about the risk benefit. I mean, if you take a look at our patients who have obesity and have 1, 2, maybe 5, 10 weight-related health complications, and you don't know everything about the medication you're putting them on, we're more willing to take on that risk
Sure.
because, the downside of not treating their medically complicated obesity is huge. So for every single patient, it's always a calculation of risk benefit.
I know it's interesting because we're in New York and, oftentimes we see people who just want this competitive edge. We hear a lot of people taking off-label, stimulants for focus. We hear people taking these obesity medications just to make sure that they're, keeping their normal weight or normal weight down. And that's a little bit scary, right? Because also, unfortunately, people with eating disorders are getting these medications, over the internet as well. What do you say to that? I mean, it's an issue too.
Yeah, it is an issue. I think that these are powerful medications that need to be prescribed appropriately to appropriately selected patients.
And, so I've gotten this question often, actually more often than I thought I would because I'm a dermatologist, but people have asked me about childhood obesity and children going on these medications.
Yeah, so same thing. It goes back to the risk benefit. If you have a child who cannot lose a pound and, their body mass index is very high and they have sleep apnea, diabetes, and fatty liver, what are you going to do?
For sure. Okay.
Right?
Yeah.
So it sounds crazy to put a child on a medication for weight, but it's not. I mean, it's just not. If someone has multiple weight-related health complications and nothing else is working, it's all about the risk benefit.
And we often see obesity, the disease, in families, right? Like there's a genetic, preponderance, possibly an epigenetic influence. So, in these families, it may be warranted. But again, it's always a risk benefit.
Always a risk benefit. Obesity medicine needs to be practiced really thoughtfully and responsibly.
Some people say if we just changed the diet of America, we would do away with obesity. Like if you go overseas, maybe there's less processed foods and there's a different, metabolism that's taking place or a different way of people are maintaining their weight. What do you say to that? Is it just the food?
Yeah. So unfortunately, there's been so much money spent on so many different kinds of prevention efforts that have not been shown to touch obesity rates.
Wow.
Obesity is so multifactorial. It's not just about people eating processed food, right?
Yeah.
So 40 to 70% is heritable. So that's a huge, it's highly heritable. And environment plays a huge role. Medications that are weight promoting play a role. Stress, sleep, so many other factors. And so, yes, changing someone's diet so that they only eat, healthy food and never eat, ultra processed food, great for health. May not work for most people who have obesity to treat their obesity and as a prevention effort, unfortunately.
Yeah. So from a population standpoint, it's not just, changing the diet everywhere. It's really—
That being said, obviously, I'm a huge proponent of, eating as well as people can,
Yes,
but,
of course.
That's not the whole answer. And you have to,
How much does sleep and lifestyle play into weight gain or weight loss? I mean, people are very busy these days. We're always multitasking, maybe not
Totally.
sleeping well.
Yeah, everyone is different. Poor sleep, especially sleep apnea causing poor sleep, plays a huge role. I mean, if you don't sleep well, your ghrelin level, which is your hunger hormone, goes up. Your
Interesting.
satiety hormones, your fullness hormones go down. And so those are just two examples of kind of hormonal shifts that happen even after one night of poor sleep. So if someone has sleep apnea and every single night they have many, many, many awakenings per night and they're not getting enough oxygen at night and not sleeping well, sleep apnea and weight gain is a really vicious cycle. So that's why when we evaluate patients, we diagnose so much undiagnosed sleep apnea and we ask about all their lifestyle factors. Talking about being a doctor and training night shifts. Oh my God. So night shifts in
I remember
themselves.
that.
Circadian rhythm dysfunction plays a huge role, or taking sleep aids to help sleep if you're on, night shifts. People take Benadryl or diphenhydramine for months and months and months. That can cause weight gain.
Wow.
So there are so many different contributors. Who knew?
Yeah. So that's a pro tip right there.
Mm-hmm.
But it's true. Like as humans, we are animals and we're very much, accustomed to a routine.
Mm-hmm.
And like everyone needs to find their healthy routine, I would say.
Totally.
And so what lifestyle interventions do you do personally? Like how do you maintain it? Because you are a founder, you're a physician, you're a mom, you're a partner. Like how do you balance everything?
Oh gosh, I don't think I balance everything. I try. It's a constant, striving for balance.
You just did a TED Talk, which is coming out soon. Yeah.
Yes. That was a lot.
Yeah.
But really exciting. I definitely love indulging, when it comes to eating. So I try to be pretty balanced in terms of when I'm eating well, I try to eat really well.
Okay.
And then when I'm not, I just let myself do that. So I feel like I'm a little bit more extreme than, people who kind of take the middle ground. And then I just try to get in as many steps as I can, and try to fit in, exercise when I can, or schedule it in.
Yeah.
That's really helpful. I mean, so many people are like, oh, I just don't have time to do this. And everyone has time to do it. You just have to prioritize it.
Yeah. I know everyone says Beyonce has the same 24 hours as everyone else.
Mm-hmm.
But yeah, it's true. I think the scheduling is super important, right? I mean, like I have to do it at the exact same time because I know if I don't do it in the morning, like towards the end of the day, things come up and, as a physician, like there's so many, last minute things. So it's really, that's been a game changer for me is the scheduling. And I think also, planning meals, I think is also helpful for me. I mean, I don't know if that's for everyone, but.
Yes, our dietitians talk to our patients a lot about meal planning because if someone's hungry and they don't have a plan, they may not make great decisions.
Yeah.
But if you plan ahead when you're not hungry and, are thoughtful about, putting together reasonable meals, that can be really helpful.
Have you seen any improvement in your patients with their skin issues with weight loss?
Yeah, that's a great question. So patients who have inflammatory skin conditions like psoriasis, for example, it is so exciting. I mean, one of the joys of what we do is hearing from patients all of the health and life benefits of obesity treatment. So absolutely, there's so many different skin conditions like psoriasis, like hidradenitis that improve with obesity treatment.
Do you know how long someone can be on these medications besides the GLP-1s, like the other medications, or?
Yeah, long term. I mean, obesity is a chronic disease, just like other
that's the
diseases.
Take-home point.
That's the take-home point. Obesity is a chronic disease, just like other diseases that you classically think of as chronic diseases. So if you start a medication for blood pressure, diabetes, cholesterol, you don't expect to solve the problem. Like, you're treating the disease, not curing it. So, the exciting thing about treating obesity is that I can start someone on one medication, sometimes 2 or 3, but prevent them from needing several others for weight-related health complications.
For sure. And, helping with their diabetes or blood pressure, I mean, it just improves their overall mortality rate as well. So, I mean, hopefully we'll see those diseases go down now. Yeah. Do you think everyone should reach out to a physician if they're starting to think about weight loss journey or?
Yeah, I don't think what we do as a company actually, just because of so much demand, is figure out kind of acuity-based scheduling.
Oh, okay.
So people with obesity, with medically complicated obesity, who've maybe tried several different interventions and nothing's worked, they may be very good candidates for an obesity medicine physician. There are not so many of us, though. I mean, I'm still one of fewer than 150 fellowship-trained obesity medicine physicians in the whole country.
Wow.
There are almost 10,000 who have taken the obesity boards, but many primary care providers have an expertise in obesity. We have, a whole team of nurse practitioners who are excellent. So not everybody needs an obesity medicine, trained physician. It depends. So we need to kind of think about, triage.
Triaging, yeah, because there's so many people that could benefit from this and really seeing which ones are most acute. Yeah. How has it been transitioning from a physician at a hospital to now the founder of your company, running a company?
It's really fun.
Yeah.
It's really exciting to be able to take our expertise and bring it to so many more people. We started the company to really democratize access to the kind of care that we deliver, and we are so committed to delivering really high-level care. So it's tricky. I mean, scaling very high-level care is hard, but we have developed technology to support our clinical care in every way possible. And we've had great success, and it's been wonderful. It's really exciting.
That's so cool. I encourage anyone who's thinking about, obesity or their obesity or weight loss to check out FlyteHealth. Yeah. That's pretty amazing that you were able to do that in such a short amount of time.
Yeah, we've been working very hard. We have a program actually with the state of Connecticut.
Okay.
And so we provide all of the medical obesity care to any state of Connecticut employee or retiree who is eligible and wants medical obesity treatment. And we did a pilot with the state that was a 12-month pilot that ended up enrolling over 7,000 people. We thought we were going to get like 500, 1,000. And looking at our data for the year, we got excellent weight outcomes and excellent health outcomes. And we did it in a way that was cost effective. Yeah. And so right now everyone's freaking out about the cost of the medications because the cost is very high and insurance coverage is spotty. And so our model has been a model that other states and other big employers and the government is looking to as, a model that's not only highly effective, but also more doable and more cost effective.
Well, you're also probably saving in the long run, right? For if you're preventing other diseases down the road. That's really cool.
Exactly. It's just, it takes a while to
find. Yeah.
It takes a little while. So that's been, harder. We're looking at a cost impact analysis of our data right now. And it's only 1 year with the state of Connecticut, but, we are seeing really positive trends, but it does take several years to kind of, get that return on investment.
And so GLP-1s have been around for longer than people think, right? I mean, I know they became popular because celebrities started to take them, but you've been using them for quite some time.
Yeah, and the first GLP-1 came out in 2005.
Yeah, I don't think people realize how long they've been around.
Right, so almost 20 years.
Yeah.
The first GLP-1 to be FDA approved for obesity was 2014.
Wow.
So that's still 10 years ago.
Yeah.
But this whole craze started when Wegovy was FDA approved in 2021.
Okay, got it. And what are you excited for in the future of obesity medicine? Are there newer drugs on the horizon? I've heard there are some drugs that mimic exercise. What's that like? What's that about?
Yeah, that we could talk about that for hours. Oh my gosh, it's a very exciting topic. What I'm excited about is, all of the medications in development and, all of the innovative ways of delivering obesity care, because we need to be really innovative right now, just given, how many people are eligible for this kind of care and how few specialists there are. So all of the innovation to me is just so incredibly exciting. In terms of medications, as I said, where the field is going, more oral options, more combination options, several medications that are in development that preserve muscle mass. So that's a whole nother topic that...
that's sarcopenia Or
Sarcopenia, yes. Sarcopenia refers to kind of low muscle mass, low muscle function. There's a big debate right now about, is it mass versus function versus, there's so many other indicators of sort of healthy muscle versus sick muscle, how that affects quality of life and health. So there are many outcomes that we're looking at, but the new medications are really exciting. They work in different ways. Time will tell what makes the most sense.
wow, that's super exciting. People have asked me about the downsides, like the thyroid risk. Is there is it really a true thyroid cancer risk? Is there obviously pancreatitis is a risk.
Yeah, the thyroid cancer has been seen in rodents
Mhm.
who were studied with super therapeutic, very high doses of GLP-1s. Rodent thyroids are very different from human thyroids. Yes, it's still a black box warning that we screen for medullary thyroid carcinoma, but one, that's extremely rare.
Yes.
Extremely
Yeah.
rare. And two, it hasn't been seen in humans. It's more of a rodent issue.
Got it.
That is a theoretical risk in humans. So we screen, it's a black box warning, but people often confuse the medullary thyroid carcinoma issue with any kind of thyroid cancer. And
Okay.
everybody has a family history of thyroid cancer.
Thyroid cancer has become more common. But you do screen for it in the beginning.
Mhm.
Okay.
And we screen for pancreatitis too.
Yeah.
If someone has other risk factors for pancreatitis, like if they're heavy drinkers, if their triglycerides are really high, those would be warnings that, maybe we shouldn't use these medications.
And speaking of alcohol, like, should people still be drinking alcohol while they're on these medications?
I recommend that people don't have more than the recommended amount. So
Yeah.
for women, no more than 7 a week. For men, no more than 10 a week. If someone's having like a drink or two a few nights a week, fine. But it's really when people are binge drinking or drinking every single day that we get more concerned.
Okay. Yeah, because it does delay gastric emptying as well, right? I know there was like some warning, with people undergoing surgery that their surgeries were being postponed because their stomach was still full and they hadn't eaten for like 12 hours. So you have to be mindful of that.
Yes.
Okay.
Again, everything needs to be kind of managed on an individual basis. So the guidelines, the pre-op guidelines are actually changing and going towards a more individualized approach.
What's been the most challenging aspect of your day-to-day job and then overall, like the whole rollout of FlyteHealth?
Yeah, that's a great question. Yeah. I think just scaling is really challenging. There's so many people who are eligible for medical obesity care, and there's so few of us who do this. And so that's why we started the company in the first place. But it's been challenging to maintain our high level of care, but also to scale. We've really used technology to support everything that we're doing, not to replace, the clinician-patient relationship or any aspect of the care team, but to really provide as much support as possible. But it's challenging. I mean, scaling is hard when you're talking about, care that has to be so comprehensive and individualized.
Yeah. Many patients have asked me, while they're on these medications, like, should I do cosmetic procedures? Should I not? Where am I in the weight loss journey? It's hard to predict like how much weight they're going to lose, right? Or you're pretty good at that now?
No. I mean, you're the expert. So I always, have my patients consult with dermatologists or plastic surgeons. I never make any recommendations. In terms of how much weight people are going to lose, we look at more health outcomes than looking at kind of an arbitrary number. So if someone comes in with multiple weight-related health complications, we'll look to improve or resolve those instead of getting somebody back to their like high school weight.
Yeah, less focus on the number, more so on the overall health.
Overall health, yeah, exactly.
That's great. I mean, I think that's a good lesson for all of us, right? Like, forget about the number on the scale, but how you feel, how rested you are, how you're performing throughout the day. And I also say that with any sort of like aesthetic procedures. It's less about, just one part and how the whole thing works together, right? I mean, it's one thing to do some, one little piece of the pie, but it's really the whole pie that makes the difference. And, we often tell people they can do tissue tightening procedures like during their treatments. Some filler does help to restore the volume that's lost because some of the facial volume is like that deep and some superficial subcutaneous fat. And it makes people look really gaunt. Yeah. It's almost like a lipodystrophy that we saw in other conditions, I would say. So it's been really fascinating from the dermatology point of view, just how fast people are losing weight. And then it does give you a little bit of an aged appearance, the thinner you are. Yeah. So
you are the expert on all that. I leave that to you. But just to address one point, we don't want people losing weight so fast.
That's a great point. Yeah.
Yeah. So when, we were talking several weeks ago and hearing stories about people losing really fast, that's concerning to me. People should not be losing that fast. People need time to keep up with eating enough protein and, doing enough physical activity to do whatever possible to mitigate any muscle loss that's possible.
Yeah. I know we talked about the devices that, contract your muscles externally, like the sort of the electromagnetic devices that make it simulate doing a lot of crunches. And, how does that help? I tell patients that, it's not necessarily going to give them a six pack, but it may help improve their functional muscle strength. And, they could do like squats better or wall sits better. So it can help, sort of improve their functional ability, which I think is cool because now we're augmenting their regular routine or their regular exercise. It doesn't replace exercise at all, but I think it helps to augment their muscle function. So there's so much on the horizon.
So much on the horizon. Yes. That was new to me. I actually, there's so much that's in your purview that I learned about recently that I just had no idea. But very cool.
Yeah. Katherine presented to a group of dermatologists and plastic surgeons all about obesity medicine and weight loss. And really because there's now an intersection, right? Like, I mean, people want to become healthier, but they're also then dealing with the aesthetic, consequences, which I think is important as well from a, just an appearance, but also a self-esteem point of view. And then there's this whole technology aspect that we're getting into. I mean, I wear this, ring that like tracks your biometrics. Do you believe in that, or like do you think it's helpful? Or
I think different things work for different people. Some people love tracking, some people hate tracking. And the most important thing is that for any individual that they figure out what works best for them and what's sustainable.
Yeah. I think that's the key of this episode is like it's an individual project through and through. And we have sort of like blanket ideas and tools that we can use, but just like in any aesthetic procedure, it's always individualized.
Totally.
You really need to focus on the patient in front of you. But I congratulate you. This is amazing. And I cannot wait to hear your TED Talk.
Thank you. Thank you so much for having me. It's been so fun to chat with you.
I can't wait to circle back in the future and just see how things are evolving.
So fast. I mean, if I come back in 6 months, it'll be a totally different landscape. So happy to come back at some point and talk about what's changed.
Amazing. Congratulations. Thank you so much.
Thank you.
Thanks so much for listening to this episode of Give Good Face. Subscribe on Apple Podcasts, Spotify, YouTube, and wherever you listen to podcasts. And follow along on social at Dr. Anthony Rossi and at Rossi DERM MD.